Hello, I'm Associate Professor Yana Simova. This is Cardiology for You. This time we are going to speak about the role of imaging in cardiac resynchronization therapy. First of all, I would like to say that the main and present indications for CRT implantations class 1A are heart failure with symptoms with functional class between 2 and 4 despite optical medical therapy, the presence of sinus rhythm and ejection fraction less than 35. Also, the QRS complex should be with LBB morphology with a duration of more than 150 milliseconds. If the QRS complex has an LBB morphology but a lesser duration between 130 and 149, then we have 1B class of indications, and if we don't have a left bundle branch block but we have an RBB morphology, then the indication is 2A. So the guidelines, the ESC guidelines from 2016 for the diagnosis and treatment of acute and chronic heart failure state that imaging tests for dyssynchrony have not yet been shown to be of value in selecting patients for CRT. But few sentences further, you could see that it is stated that pacing thresholds are higher in scarred myocardium, and if possible, lead placement should avoid such regions. And how should we avoid such regions if we don't use imaging techniques? So imaging techniques indeed had a role in selection of patients for cardiac resynchronization. We know that the response to CRT is the main thing that determines the prognosis of our patients. We know that 30 to 40% of CRT implants don't have clinical response. They are non-responders, and up to 50% are echocardiographic non-responders, which means that they do not have a reverse remodeling of the left ventricle. And namely here, imaging improves the selection of CRT candidates with higher probability of response to therapy. So speaking about dyssynchrony, we have main distinct kind of dyssynchronies, and these are the electrical and the mechanical. We have some patients who have mainly electrical dyssynchrony with wide QRS complexes but without mechanical dyssynchrony. Here we still don't have evidence for the benefit of the CRT, and we wait future trials. Then we have the other side, the patients with only mechanical dyssynchrony who don't have electrical, they have narrow QRS complexes. And here we have several studies, you will see later, that show no benefit of CRT, but we await further studies which would give another evidence about this issue. In the middle are the patients that we target. These are the patients with both electrical and mechanical dyssynchrony, but again here there is a gradient of response, and it depends on the viability of the myocardium, the venous anatomy of the heart, and the sites of delay. So speaking about dyssynchrony, the main thing is to say that we have several types of dyssynchrony. One of them is the dyssynchrony between the atriums and the ventricles, the atrioventricular dyssynchrony. Then we have the dyssynchrony between the right and the left ventricle, the so-called interventricular dyssynchrony. And then we have the dyssynchrony within the left ventricle, the so-called intraventricular dyssynchrony. Let us first talk about the atrioventricular dyssynchrony. This which is important not only for CRT but also for DDD pacemakers. It could be measured in several ways, and the most common of them are the iterative method, the Ritter's method, and the method with the LV outflow tract measurement of the VTI. So the optimal AV delay is when there is enough separation and no fusion of the E and the A waves and no truncation of the A wave. When the AV delay is too short, that the A wave is too close to the next systole, and then we have a truncation of the A wave which limits the atrial kick and diminishes the stroke volume of the left ventricle. When we have a too long AV delay, when we have the P wave and the A wave too late in diastole, then we have a fusion of the E and A wave. In this case, you see an example of it, the fusion of the E and A wave, and we have a short duration of diastolic filling time, which is less than 40% of the heart cycle, and this is not good because it does not allow enough time for the left heart to be filled with blood and to eject enough of stroke volume into the systemic circulation. So, what is the iterative method? It is the most common echo optimization technique. It consists of programming first a relatively long AV delay with gradual shortening in 20 millisecond steps until we have a truncation of the A wave. Then we start to prolong the AV delay in 10 millisecond steps to the time when we have the maximal E and A wave separation without the truncation of the A wave. Let's see how it works. So, first we have a relatively long AV delay, 160 seconds. In this case, you see that we have a fusion of E and A wave, and if we measure the diastolic filling time, it is short, 338. Then we decrease the AV delay with 20 milliseconds to 140. Now we see a more clear separation of the E and A wave, and the diastolic filling time prolongs to 394 milliseconds. Then we further shorten the AV delay to 120 milliseconds, and now we have a very distinct separation of the E and A wave without truncation of the A wave, and we have the diastolic filling time of 432 milliseconds. And if we still try to shorten the AV delay to 100 milliseconds, yes, indeed, we have a very nice separation of the E and A wave, but we have this truncation. You see how abruptly the A wave ceases, and indeed the diastolic filling time here decreases. So we must go a few steps behind and select the optimal AV delay. So now we come to the next method, which is the iterative, which is the Ritter's method, This consists of measuring the interval from the QRS onset to the end of the A wave at a relatively long and relatively short AV delay. Then the difference between these two is subtracted from the long AV delay in order to arrive to the optimal AV delay. Let's see how this happens. This is the time between the onset of the Q wave and the end of the A wave at a relatively long AV delay. And this is the interval between the onset of the Q wave and the end of the A wave at a relatively short AV delay. The difference between these two times is 100 milliseconds. We distract this difference from the long AV delay, which is 200, so 200 minus 100, and we derive to the optimal AV delay, which is 100 milliseconds. So another way to measure the optimal AV delay is to measure the aortic VTI, and we try different AV delays in order to arrive at the largest VTI of the aortic valve. Now we come to the interventricular dyssynchrony, or the dyssynchrony between the right and the left ventricle. Such a dyssynchrony is present when the difference in the pre-ejection times of the both ventricles is more than 40 milliseconds. How is this measured? We measure the time between the onset of the QRS complex and the onset of the pulmonic flow at parasternal short axis level at the aortic valve. Then we measure the time between the onset of the QRS and the onset of the aortic flow in again with pulse wave Doppler in some of the apical views. And if this difference is more than 40 milliseconds, then we have interventricular dyssynchrony. How could this be optimized? Mainly with the measurement of LV, outward tract VTI. So when the left ventricle contracts, first these are the minus signs. We measure VTI, we measure stroke volume. Then when two ventricles contracts at the same time, the value is 0, and the right ventricle we have the plus values. At each value we measure the VTI and the stroke volume. And in this example you could see that when the right ventricle is first with plus 30 milliseconds, we have a VTI of 8.9. When we have both ventricles contracting simultaneously, we have a larger VTI of 9.1, and when we have the left ventricle contracting before the right, minus 30, we have the largest VTI, which is 9.5 centimeters. Do we have to do these measurements in all patients? It is still not clear if this is necessary for all patients, or we should use the Empyrean device programming. There is also no consensus on when and how CRT optimization should be performed. And now we come to the LV dyssynchrony and how to measure LV dyssynchrony. It depends on the expertise of the echocardiographer and the scanner that he or she uses. One of the most simple ways is the M-mode, so-called index of Pizzalis, which measures the septal water wall delay with the cutoff point with 130 milliseconds. Another very important point is the septal flash phenomenon. I will come to this further. It is an abrupt movement of the septum towards the left ventricle in early systole, followed by mid and late systolic lengthening of the septum. Then we have the tissue Doppler measurement of LV dyssynchrony. This is the maximal delay between the opposite walls, septal and lateral and anterior and posterior. It is pathological if it is more than 65 milliseconds. We could also measure tissue Doppler strain in the parasternal short axis view, the time to peak radial strain between septal and the posterior wall with the cutoff again as the index of Pizzalis of more than 130 milliseconds. We could do this also with speckle tracking, the radial strain, anterior septum, posterior wall delay, again more than 130 milliseconds. Also, global longitudinal strain has very strong prognostic implication with values less than -9%, leading to better survival free from death, LV-assist device or transplantation, and better survival free from death or hospitalization. We could also measure LV desynchronization with dysynchrony with 3D methods if we have a scanner with such capabilities. Here is an example of how to measure the standard deviation of time to minimal volume of 16 or 17 segments with a cutoff point of 9.8%, and an example of a totally synchronous left ventricle and totally dysynchronous left ventricle. We could also measure 3D synchronization with 3D tissue synchronization, standard deviation of time from the maximum systolic velocity of 12 segments, and we could also use 3D speckle tracking. A very interesting thing is the option to use fusion imaging. This is a way to fuse the image of the left ventricle with the zone of the maximal delay with the coronary venous anatomy in order to be able to select which branch would be most suitable to position the LV lead in order to provide the optimal synchronization of the left ventricle. Another very important issue is the apical rocking, this kind of strange movement of the apex when we have a dysynchronous left ventricle. This could be analyzed entirely visually, but this group of authors have developed a method for a quantitative measurement of apical rocking. The apex moves in a way that is perpendicular to the ultrasound beam, so it could not be measured directly, and they accept this apical region as a cap and measure the velocity of the septal and lateral rim of this cap. And these are these two kinds of velocities. When they are integrated, we have the movement of this apical region of the left ventricle. As I have said, both the apical rocking and the septal flash are very important predictors after CRT for the response and for the survival of these patients. Also, another very important thing, these are patients with implanted CRT. You could see that the best survival is for the patients who have wide QRS complexes more than 150 with apical rocking, which has been corrected, but also patients with not so wide QRS complexes, less than 150, but with apical rocking that has been corrected, has the same very good prognosis. The worst prognosis is for the patients which have not so long QRS complexes, less than 150, without apical rocking, or the apical rocking has not been corrected, but the same worst prognosis is also seen in those patients who have wide QRS complexes more than 150 without apical rocking or with such a thing which has not been corrected. So the apical rocking is a more important issue in resynchronization therapy. Why some patients respond and why do not when the common criteria are the same for all? Maybe because LBB are not the same in all patients. Here in a study, a group of authors have described 3 types of LBB patterns. The first time, the pattern 1, is we have double peak systolic shortening. Then in pattern 2 we have an early pre-ejection shortening followed by a prominent systolic stretch, and in the pattern 3 we have a pseudonormal shortening with a late systolic shortening of the septum. So 92 of the patients of pattern 1 and 2 have been responders to CRT, while only 59 with pattern 3 have been responders. LV volumes, ejection fractions, and GOS respond more favorably when the LBB pattern has been 1 or 2 and less favorably when it has been pattern 3. Also survival, event-free survival is 95% in patterns 1 and 2 and 75% in pattern 3. Of course, CARS is also a thing that matters a lot, so CRT does not reduce the LV dyssynchrony in patients with transmural scar tissue in the posterolateral LV segments. And this is a study showing the change in the end-systolic volume. You see that it is greater when we have non-ischemic disease and lesser when we have ischemic disease. But even in this, we have subgroups of patients with lead position remote from the scar with a better response and patients with a lead position adjacent to the or within the scar which have the worst response. Can CRT in fact aggravate heart failure? And this is the answer from the APO-CRT study of more than 800 patients, who says that in patients with heart failure and the QRS duration of less than 130, CRT does not reduce the rate of death or hospitalization for heart failure and may indeed increase the mortality. So indeed we should be very careful about selecting our patients. So the magnitude of the benefit for CRT is highest and responders are more when we have wider QRS, LBB, female gender and non-ischemic cardiomyopathy. The magnitude of benefit is lowest and we have most non-responders with narrower QRS complexes and non-LBB morphology, and in the middle stay the males and with the ischemic cardiomyopathy. And in this puzzle of a multifactorial issue for the non-response, we have a connection between myocardial scar, irreversibly advanced heart failure, lack of dyssynchrony, optimal AV and VV optimization, and LV lead placement, and also factors that we still don't know. This was all from me, dear colleagues. I hope that this has been useful for you and for your future practice. If you feel so, you could always share this with other colleagues who would benefit from this kind of information. If you have some questions, please feel free to write them in the